morning and a very warm welcome to Online Anesthesia. An anesthesia update is Zoom platform sponsored by Akrulla and hosted by A1 Logics. And our media partner is Anesthesia TV. Today we have two interesting topics in Neuro-anaesthesia update. The first topic is perioperative management of patients with the previous stroke coming for non-neuro and non-cardiac surgeries by Dr. Manisha Madam. It is a less discussed topic in all anesthesia forum. And the second topic is the review of positioning and ventilation in neuro-anesthesia by Dr. Joseph N Monteiro. And we have an eminent scholar and academician, Dr. Divatia sir, as a moderator today's session. I am happy to introduce our moderator, Dr. Divatia sir. Dr. Divatia sir is working as a professor and head of Department of Anesthesia, Critical Care and Pain at Tata Memorial Hospital, Mumbai in India. And he is the president-elect of Indian Society of Anesthesiologists and past editor-in-chief of Indian Journal of Anesthesia and past president of Indian Society of Critical Care Medicine. And he has published more than 190 publications in national and international journals. And his area of interest is airway management, onco-anesthesia, hemodynamics, and mechanical ventilation. We are honored by your presence in our platform, sir. Over to you, sir.
Good morning, and thank you, Dr. Edward Johnson, for having me in this program. I think you've been doing a great job with this series and online anesthesia over the last year or so. And it's really an excellent educational initiative that you've taken. And I think it's been consistent and doing extremely well. And I think today's topics and speakers are going to be, again, provide exceptional value to all our listeners and all of us. So like you mentioned, is, something considered exotic, but there are lots of neurological problems that patients have that we come across in the course of general anesthetic practice. And the first talk will be on the management of patients with a previous stroke, and that will be given by Dr. Manisha Katikar. She is Chief Anesthesiologist and Intensivist at the Balwant Institute of Neurosurgery and Intensive Traumacare at Solapur in Maharashtra. She's also an associate professor in the anesthesia department at the Ashwini Medical College, Solapur. She's been extremely active in Maharashtra. She's been the past president of the Maharashtra ISA. She's also extremely interested in academics. She's an associate editor of the Indian Journal of Anesthesia. And she's received a number of awards from the IJ and the ISA, including the Rukmini Pandit Award at ISACON in Ahmedabad 2021. She's been practicing neuroanesthesia and neurointensive care for many years, and she's a highly regarded specialist in the field. And it is my privilege to introduce Dr. Manisha Katikar and invite her to speak on the topic.
Thank you, sir. I think it is a great honor for me that my teacher from Tata Memorial Hospital, Dr. Divatia sir, is introducing me. At outset, I would like to thank the organizers, especially Dr. Edward Johnson, sir, for inviting me on this prestigious dais of online update of the anesthesia online classes. And I am extremely happy to be there. Second thing I would like to mention about this topic, the perioperative management of patients with previous stroke for non-neuro and non-cardiac surgery. I myself feel that this is a very much neglected topic. And if you refer to any textbooks, you will not find a material together for management of such kind of patients. So it is very important to discuss a patient who comes for non-neuro or non-cardiac surgery and who has suffered from previous stroke. And the anesthesia management matters a lot because the most important complication of a previous stroke patient coming to the surgical intervention is again occurrence of fresh infarct or fresh stroke. So in next 25 minutes, 25 to 30 minutes, let's see how will you manage such kind of cases. We commonly face such kind of clinical scenarios. A 62-year-old male patient, non-hypertensive and diabetic, a case of previous stroke 10 years ago with residual neurological deficit, with a tracheostomy scar, admitted with fractured left femur. Patient is on antihypertensives, antidiabetics, and clopidogrel and aspirin. Another case scenario, 75-year-old male female patient, non-hypertensive and diabetic, a case of previous stroke 10 months back with no neurological deficit, admitted for cataract surgery. She is on antihypertensive, antidiabetics, and dabigatran. Third scenario, a 42-year-old female patient who had a history of previous strokes 6 months back with no neurological deficit, admitted for emergency exploratory rhabdotomy, and patient is taking warfarin. We do face such kind of clinical scenarios in our day-to-day practice. And in next 20 to 25 minutes, let's explore what kind of perioperative care as far as anesthesia management and the intensive care management is concerned, and that has to be offered to this kind of patients to avoid all post-operative complications. So in a layman's language, everyone knows heart attack, but my clinical experience tells me that very few patients know about what is called as a stroke. If you try to dig into the history, they may not be aware if it is a transient ischemic attack or and the seriousness of that stroke or that transient ischemic attack on this surgery, on this non-neurological or non-cardiac surgery, and that has to be explained. In fact, the history has to be digged in detail, and that has to be explained in the patient in a very certain terms that this is the same what has happened to you like in heart attack, and this will produce serious consequences depending upon the drugs that the patient is taking, the kind of surgery that the patient is exposed, and the urgency of surgery. So let's see how you manage this type of patients. So WHO defines stroke as a neurological deficit of sudden onset with focal rather than global dysfunction, in which after adequate investigations, symptoms are presumed to be of non-traumatic vascular origin, and these symptoms last for more than 24 hours. So whenever you get a patient of previous stroke, the patient might be with complete neurological deficit, recovery without any deficit, or patient may have aphasia, hemiparesis or hemiplegia, monoparesis or monoplegia, which he will explain in his language as trouble in walking, seeing, speaking, and there is weakness on one side. So detailed history of previous stroke has to be asked to the patient. When did it occur? What was the type of stroke? You have to see all the discharge card and summaries and the previous reports of that episode of previous stroke. You must ask what secondary prevention medications that the patient is taking. Is he on antiplatelets, anticoagulants, antihypertensive, statins? Is there any residual neurological deficit from the stroke, from that previous stroke? And all detailed investigations like brain imaging, MRI, a CT scan, correlative Doppler ultrasound, ECG, echo, that has been done in that previous stroke episode has to be seen in detail and has to be documented on paper in the preoperative assessment. You also must ask any history suggestive of transient ischemic attacks, any history of comorbidities like hypertension, diabetes, IHD, hyperlipidemia. It is also very important to ask symptoms such as memory lapses, altered emotional behavior, inability to express, this because this may be positive indicator of previous undiagnosed stroke, and all these findings must be documented in their preoperative assessment. The detailed history of the drugs that the patient is taking, antiplatelet agents, anticoagulants, statins, beta blockers, antihypertensive drugs, antidiabetics, anticonvulsants, antiarrhythmic agents, all should be noted down, especially when did the last dose was taken. There are certain independent risk factors which are associated with perioperative stroke that have also to be noted down: age, gender, any history of smoking, cerebrovascular accident, prior transient ischemic attacks, valvular diseases, atrial fibrillation, coronary artery disease, acute renal failure or hemodialysis, patent foramen oval, diabetes, hypertension, COPD, and congestive heart failure. All these are independent risk factors which will affect the mortality and morbidity associated with the perioperative stroke, and that has to be also noted, and that has to be noted in your preoperative assessment. Another important aspect is the history suggestive of silent cerebral ischemia or covert stroke, which may be there in the previous when the patient has sustained previous stroke, and in the period when the patient comes for the surgical intervention. This may be associated with cognitive decline, dementia, and these patients have again increased risk of stroke after the surgery and perioperative delirium. The incidence of such silent cerebral infarcts after non-cardiac surgery has been found to be as high as 7%, in a multi-center prospective study of 1,114 patients undergoing elective non-cardiac surgery. So after a detailed history and assessment, you must see the patient clinically. Pulse should be assessed clinically to find out whether it is a regular or irregular. If it is irregular pulse, it is important. Blood pressure should be assessed in the sitting as well as supine position, and extent of neurological deficit has to be assessed in detail and documented in the pre-anesthetic assessment. Cardiac evaluation with ECG is very important. If the ECG is suggestive of atrial fibrillation, and that is very important as far as occurrence of or management of perioperative stroke is concerned. So we will see next 2 to 3 slides about it. And if there is electrolyte imbalance or there is dehydration, it needs to be corrected. A study was published by All Nippon Atrial Fibrillation in Elderly Registry, where they examined almost 32,275 patients who were aged more than 75 years and who had non-valvular aortic atrial fibrillation. Amongst them, 7,304 patients had previous history of stroke or transient ischemic attack. And when these patients were subjected to further surgical intervention for non-cardiac surgery, it has been found that there was a significant incidence of stroke and systemic embolization in these patients who had previous history of stroke as well as previous history of non-valvular atrial fibrillation. And that is why the importance of detecting atrial fibrillation is very important in patients who come with previous stroke for any surgical intervention. A CHAD score has been also established to find out the risk of stroke in patients who have non-valvular atrial fibrillation. And you need to calculate, if the patient has atrial fibrillation, you need to calculate this score to find out the risk factor, because there is a high risk of stroke in the perioperative period if the CHAD score is 5 to 6, moderate if the CHAD score is 3 to 4, and low if the CHAD score is 0 to 2. Another important thing in the preoperative assessment is to find out patent foramen well, which is present in almost 25% of the population. A retrospective study of around more than 150,000 patients who underwent non-cardiac surgery with GA have found significantly increased likelihood of perioperative ischemic stroke if the patient has patent foramen well. The severity of the stroke is more, and it is likely to occur in a large vessel territory. So a preoperative assessment of patent foramen well is also important in these patients who have previous stroke and who come for non-cardiac surgery. Assessment of lipid profile, 2D echo, stress test if required depending upon the patient situation, and coronary angiography has to be individualized depending upon the patient, but these two investigations should be done in every patient. The role of and the importance of doing a carotid Doppler, which is a bedside imaging technique, which helps us to get, it is a non-invasive technique, which helps us to identify the carotid disease. If the previous reports are available, you can compare with the previous report and find out the percentage of blockade of carotid arteries, whether it is a unilateral blockade or a bilateral blockade. This also tells you about the risk of perioperative score. It is reasonable to recommend that all patients with a history of TIA or a previous stroke within the preceding 12 weeks should undergo carotid imaging. In asymptomatic patients with no neurological symptoms or signs, routine carotid imaging is not recommended, and the benefits of revascularization are also questionable. The next important thing you need to find out is what is the type of surgery, whether it is a high bleeding risk, a moderate bleeding risk, or a low bleeding risk surgery, and that will help you in further management of antiplatelets and anticoagulants which the patient is taking. A consensus statement has been published in Journal of Neurosurgical Anesthesiology in 2014, which tells us about moderate to high risk surgeries and low risk surgery. The clinical case scenarios which we had seen, one was a fracture femur, another was exploratory laparotomy. All these fall into moderate or high risk surgery, and the third scenario was a cataract surgery. It falls into the low risk surgery. When we should operate a patient who has suffered from previous stroke, this is also important. How long we should delay giving anesthesia to that patient after previous stroke. Why this is important? Because in patients with recent stroke, There is impaired cerebrovascular autoregulation and chemoregulation for months. Cerebral perfusion pressure is very sensitive to even modest changes in blood pressure, and there is a risk of cerebral hypoperfusion, especially under general anesthesia. This duration of failure of autoregulation is uncertain, but it has been postulated that it may last for 1 to 3 months. Furthermore, the area of infarcted cerebral tissue undergoes inflammatory process and softens, rendering this area vulnerable to hemodynamic stresses of anesthesia and surgery. In patients who had a recent stroke or transient ischemic attack, current evidence suggests that it would be safer to delay elective surgery for 3 months. But of course, we need to take an individualized decision depending upon the urgency of the surgery and depending upon the risk of the patient that the patient may going to suffer for the perioperative stroke after undergoing the surgery in the first 3 months after sustaining the stroke. The two studies that has been published, especially the most important study that has been published by Jorgensen et al., that gives an idea about the risk of perioperative stroke in patients who had prior stroke within 3 months. They have studied, they have found out the relation between the previous stroke and the risk of major adverse cardiovascular events and a large sample size. And in the patients who had undergone non-cardiac surgery, and they found that there is a significant risk of stroke in the perioperative period for such kind of patients, and the risk reduces once the time passes, and the risk is highest within the first 3 months after the surgery, after the previous stroke, and as the time passes, the risk reduces, and after 9 months of an ischemic stroke, the risk remains same as far as those who did not have prior stroke. So this is an important landmark study that has given us an indication when to operate such kind of patients, what should be the ideal time to operate such kind of patients who have suffered from previous stroke. The SNACC consensus statement regarding the definition of perioperative stroke mentions it is an infarct of ischemic, thrombotic, or hemorrhagic etiology which occurs during surgery or within 30 days after the surgery. And the most important predictor, and we are worried always about it, is the previous history of stroke, and outcomes that are associated with such an event are extremely poor. So if a patient who has a previous history of stroke again sustains or suffers from perioperative stroke, the prognosis is going to be poor, and the highest risk of such recurrent events is seen in first 1 month. The reported incidence from the non-cardiac surgery has been mentioned in literature to range from 0.1 to 4.4%. However, I feel these are the tip of iceberg cases, as we do not keep the patient admitted for 30 days after the admissions. So many minor strokes or transient ischemic attacks are likely to be underreported. So what is the pathophysiology of this perioperative stroke? Various mechanisms have been explained for the patients who are undergoing non-cardiac and non-neurological surgery. There may be hypotension, low flow slates, previously undiagnosed large artery stenosis, anemia-associated tissue hypoxia, thromboembolism, fat embolism, and surgery itself can contribute for inflammatory response with endothelial dysfunction, and the recent stoppage of antithrombotic medications can lead to a hemorrhagic episode. So all these factors are important as far as the risk of perioperative stroke is concerned. So let's see now how you manage the anticoagulants and antiplatelets drugs and when they should be stopped prior to surgery. There are important concerns, especially if the patient is on atrial fibrillations, and also in patients who are taking aspirin, which is started for the stroke prevention. So you need to balance between intraoperative bleeding and perioperative stroke. The perioperative management of such group of patients need careful consideration to minimize the thrombotic risk, and a comprehensive individualized approach is crucial. Evidence is lacking in the settings of non-cardiac surgical intervention. Perioperative withdrawal of antiplatelets or anticoagulants and postoperative immobility can aggravate a surgery-induced hypercoagulable state, thus increasing the risk of perioperative cerebral thrombotic events. As I mentioned already, surgery itself increases the inflammatory response, and previous recent stroke is a prothrombotic stage. With this, both pre-atherogenic and prothrombotic stage together the previous stroke and surgery together definitely increases the mortality related to the stroke. So the management of anticoagulants and antiplatelet drugs is very important. Recommendations are to medically manage atrial fibrillation, discontinue anticoagulants, stop appropriate bridging strategies, resume anticoagulants early and when safe. So the approach to these patients of preoperative bridging for anticoagulation management depends upon the thromboembolic risk and also depends upon the surgical intervention, whether it is a high bleeding risk procedure or a low bleeding risk procedure. If the patient is taking aspirin, warfarin, and there is a risk of high thromboembolic risk, it is better to give the last dose, 6 dose before the surgical intervention, bridge them with heparin, and the drug can be resumed 24 hours post-operatively when it is safe that there is no, again, bleeding risk associated with warfarin. For low bleeding risk surgical intervention, the same way we have to manage. For the patients who are taking direct acting oral anticoagulants, it is always in a high thromboembolic risk patients and with a high bleeding risk procedures, it is better to give last dose 3 days before surgery, and you can resume them post-operatively after 2 to 4 days. If it is a low bleeding risk surgery, give last dose 2 days before operation and resume 24 hours post-operatively. If there is an intermediate thromboembolic risk, then when there is a high bleeding risk procedure, you determine the need for bridging by clinical judgment and current evidence. For warfarin, for direct anticoagulants, give last dose 3 days before the surgery, the same way you did for high risk surgery. And the management for low bleeding risk is almost same as that for high bleeding risk surgery. If it is a low thromboembolic risk, for warfarin, bridging is not recommended, and for both high as well as low bleeding risk procedures. And if the patient is on direct oral anticoagulants, the management is almost same as for the high as well as intermediate thromboembolic risk patients. When this drug should be stopped? Yes, this should be guided by an individualized assessment of bleeding and thrombotic risk. Aspirin should be continued for all non-cardiac and non-neurosurgical cases, with the exception of specific surgeries type like a closed space surgery. Clopidogrel should be stopped for 7 days. Warfarin should be stopped for 4 days before surgery. And if the patient is on non-vitamin K oral anticoagulants, they should be discontinued between 1 to 4 days pre-operatively according to the renal functions and the surgical bleeding risk. If the heparin has been started for bridging therapy, intravenous heparin should be held 4 to 6 hours before elective operation, subcutaneous 12 to 24 hours before elective operation, and low molecular weight heparin 24 hours before the surgical intervention. If the patient is on dabigatran with normal renal function, it should be omitted 2 days before surgery. If the patient has impaired renal function, it should be omitted 4 days before high bleeding risk surgery. If the patient is on rivaroxaban, apixaban, or endoxaban, it should be also omitted for 2 days before surgery for a high bleeding risk operation. If the patient is taking clopidogrel, prasugrel, or ticagrelor, then it should be held for 5 to 7 days before a low and high bleeding risk operation. And this protocol should be followed for every patient who is taking antiplatelets and anticoagulants. Now suppose your patient comes for emergency surgery. As the case scenario 3, where the patient has to be subjected to the emergency exploratory tracheotomy and patient is on warfarin. So if the patient is on vitamin K antagonist like warfarin, you need to administer vitamin K and 4-factor prothrombin complex concentrate to this patient. If the patient is taking dabigatran and patient has to be subjected for emergency surgery, administer idarucizumab to the patients who have significant dabigatran levels and there is a risk of bleeding. The patients, if you is on other direct acting oral anticoagulants, administer 4-factor prothrombin complex concentrate for reversal of the coagulant effects and also avoiding the bleeding risk. And if the patient is on antiplatelet agent, transfuse 1 pooled unit of platelets immediately before operation, and redosing is needed for if there is a risk of ongoing bleeding. The American College of Chest Physicians has suggested thrombotic and bleeding risk stratification strategies, and bleeding risk scores such as HAS-BLED has also been used, and this can be used clinically to assess the bleeding risk. What about role of preoperative antihypertensives and statins in the perioperative period? If the patient is taking beta blockers and statins, continue it throughout the perioperative period. If the patient is taking metoprolol, it has been mentioned in the literature that there is a high risk of post-operative stroke and clinically significant hypotension and bradycardia. If the patient is taking bisoprolol, it is safe. If the patient is on statins, continue it because it has been found that clinically that there is a reduced incidence of atrial fibrillation and adverse outcomes. Intraoperative use of escolol is recommended. De novo beta blocker therapy is not routinely indicated unless there is a new diagnosis of coronary artery disease. The famous POISE study, which has been published in Lancet 2014, has already mentioned that there is increased mortality and higher stroke rates in patients treated with preoperative betaprolol compared with placebo. So the risk of perioperative stroke or aggravation of neurological symptoms should be discussed preoperatively with the patient, and it is very important for all non-cardiac, non-neurological, or in fact any surgical intervention in a patient who has suffered from previous stroke, and informed consent should be obtained. Does the type of anesthesia change your stroke risk? That has also to be ascertained. We all know about the neuroprotective effects of general anesthesia. Nitrous oxide may impair endothelial function, leading to adverse cardiovascular outcome and stroke. However, there is no evidence that suggests the increased risk of perioperative stroke with the use of nitrous oxide. Neuroaxial techniques may be associated with low incidence of perioperative stroke for hip and knee orthoplasty. No such data exists for other surgeries. There is currently insufficient evidence to support the use of regional versus general anesthesia to lower perioperative risk of stroke. So the decision to choose GA versus regional does not appear to impact stroke risks, with possible exception of patients undergoing joint orthoplasty. Benefits of central neuroaxial blockade must be balanced against increased risk of cerebrovascular thrombosis related to withdrawal of clopidogrel therapy. Exposure to anesthesia and surgery has been found to be an independent risk factor for development of a new stroke even after non-high-risk surgeries. Two important trials, the Myriad trial and the NGMA2 trial. The Myriad trial was done in patients who had to undergo cardiac surgeries, and where they compared the volatile best technique and the propofol anesthesia. They found no difference of stroke risk, and the risk was similar between both the groups, the volatile anesthesia group and the propofol group. The NGMA2 trial, which evaluated the use of nitrous oxide in patients and no nitrous oxide in patients who were subjected to non-cardiac surgery, and there was no association between nitrous oxide and stroke at 30-day or 1 year follow-up period. Thus, for general anesthesia, the choice of maintenance technique does not appear to impact stroke risk. In 2018, the Perioperative Neurotoxicity Working Group also published a set of recommendations for best practices for brain health, and they mentioned that there is a little evidence that inhaled anesthesia agents increase the risk of perioperative neurocognitive disorder. So the article that has been published in Anesthesia and Analgesia in 2018 mentions that the evidence to date suggests that anesthetic agents are neither neuroprotective nor neurotoxic, and the choice of anesthetic agent is unlikely to influence the risk of stroke in the perioperative period. Two large retrospective studies done in a large sample size also suggested that neuroaxial anesthesia may be weakly associated with fewer strokes compared to general anesthesia in patients undergoing hip surgery. There is currently insufficient evidence to support the use of RA or regional anesthesia versus general anesthesia alone that will help to lower the risk of perioperative stroke. So the type of anesthesia, as far as whatever the literature is mentioned, do not have any impact on occurrence of any complications if the patient is subjected to surgery who has a history of previous stroke. For intraoperative monitoring, along with the routine monitors, you may need additional monitor depending upon the surgical procedure and the patient's condition. Invasive blood pressure, CVP, and urine monitor should be monitored. Urine output should be monitored to ensure stable hemodynamics. If you are monitoring neuromuscular junction, it should be done on unaffected side. And in a high-risk patient, you may need further advanced neurological monitoring, especially if the patient, there is a significant risk of developing perioperative stroke. Blood sugar should be monitored throughout the perioperative period, and a target range of 120 to 180 milligram per dl is recommended. It is also very important to avoid any episode of intraoperative hypotension because it will lead to ischemic stroke. And so it is very important to maintain normotension throughout the period. An important study was published in Anesthesiology 2012, where they found that stroke increased by 1.14-fold for every 10 minutes of hypotension, which is defined as the mean blood pressure, fall in mean blood pressure, 30% of 30% less than the baseline. There is a lack of consensus regarding optimal perioperative blood pressure target, so it has been suggested to maintain the mean arterial pressure above 70 millimeters of mercury intraoperatively to reduce the risk of perioperative stroke. It is very important to avoid intraoperative anemia as it can lead to ischemic stroke. So for non-neurological, non-neuro surgeries or non-cardiac surgeries, avoid hemoglobin less than 9 g/% to minimize the risk of stroke. You have to maintain normal ventilation and normocapnia throughout the surgical procedure. Avoid hypoventilation and hypocapnia, and this can lead to significant reduction in cerebral blood flow. Recovery from anesthesia. It is very important to ascertain the recovery of protective airway reflex when you extubate the patient. An ischemic brain may respond differently to the anesthetic agent than a normal brain, so please remember this. Immediately on awakening from anesthesia, there may be short-term unilateral delay. There may be short-term delay of return of motor function, which has been labeled as differential awakening, and that has been noted on the affected side. And thus, this patient should be observed clinically in the perioperative period. And the recovery from anesthesia, after recovery from anesthesia, neurological function should be assessed at the earliest. And if you find any new motor deficits, this patient should be closely monitored in the intensive care unit. And if these deficits persist, further radiological testing is needed. Another terminology, re-emergence from neurological deficit. A patient who has suffered from ischemic stroke or patients with previous transient ischemic attacks who had suffered from hemiplegia or major neurological deficits and has recovered significantly over time, or patients with previous transient ischemic attacks can again show re-emergence of previous neurological deficits after exposure to benzodiazepines, opioids, or after general anesthesia. Remember that this phenomena is transient, but you have to monitor these patients very carefully, and these patients usually recovers in a short time. What is the mechanism for this kind of re-emergence of neurological deficit phenomena? It has been mentioned that drug-induced reduction in cerebral perfusion in the penumbra area is considered contributory for occurrence of this kind of neurological deficits. Post-operatively, as I said, the most devastating complication is perioperative stroke, which is the occurrence of ischemic or hemorrhagic etiology within 30 days after surgery. And as an anesthesiologist and an intensivist, it is very important to monitor the patients for perioperative stroke in the post-operative period. The recognition of such patients is critical. Continue statins in the post-operative period. Use beta blockers judiciously. Recent evidence suggests that continuation of aspirin in a patient at risk of stroke may increase the bleeding risk. So we have to respect the bleeding risks that has been associated with aspirin. Post-operative vigilance and appropriate stroke screening is needed in high-risk patients. Does carotid artery stenosis predict perioperative stroke? Yes. If there is a more than 70% stenosis of carotid artery, usually these patients are symptomatic, so you need to revascularize this patient either by carotid endarterectomy or stenting prior to elective surgery. If the carotid risk is less than 50%, these patients do not need revascularization. And between 15 to 70% of stenosis of carotid artery, you again need to, and if the patient is symptomatic, then also you need to should be considered for revascularization, and you need to assess these patients very carefully if they come for non-cardiac or non-neurological status. Identification and treatment of perioperative stroke is very important. as most of the episodes occur in first 24 hours after surgery. And why the identification is difficult and challenging? Because many a times for major surgery, if the intubation is prolonged, like our case scenario 3, where the patient, when there is emergency exploratory laparotomy, and if it is a major due perf or intestinal obstruction, we may continue to ventilate this patient in the postoperative period. If there are residual effects from anesthesia, or if there is a use of opioids and other psychoactive medication, then it is very difficult to recognize perioperative stroke. The hallmark is sudden onset of focal neurological deficit. There may be clinical presentation like a non-fecal episodes with patient showing neurological status changes like agitated delirium, instability, or delayed emergence from anesthesia. So this also should be given special importance in patients who have suffered from previous stroke. Post-anesthesia care unit should consider routinely performing neurological assessment for early identification of stroke in high-risk patients, and staff members in these units may require additional training in performing neurological assessment. Various scales like FAST scales can be used in the post-surgical wards to assess occurrence of perioperative stroke, like examination of face, arm, delayed effects of anesthesia, or speech can also be assessed. It is very important to identify the occurrence of perioperative stroke in the immediate post-operative period, as you should not waste time. If there is a persistent neurological deficit, the patient must get a neurological help immediately, and the neuroimaging techniques has to be performed immediately. So just to summarize, in the preoperative period, find out the independent risk factors. Preferably delay the surgery at least for 6 months, preferably 9 months from the time of incident of stroke. If there is a significant carotid stenosis, more than 70%, the patient may be advised to undergo carotid revascularization. Use of adjustment of medications such as statins, beta blockers, and antithrombotic agents should be based on existing guidelines. Consider non-surgical treatment if it is available, and it should be discussed with patients and caregivers as an alternative surgery in patients who have elevated risk of stroke. In the intraoperative period, maintain blood pressure, mean arterial pressure above 70 millimeters of mercury. Avoid anemia. There is insufficient evidence to make clear suggestions on the use of general anesthesia versus regional anesthesia. Maintain normocarbia, normocapnia. Use lung protective ventilation strategies in this patient, and hypocarbia should be avoided. It is very important to identify a perioperative stroke. The incidence is higher within first 72 hours. So the staff in the perioperative care units should be specially trained to assess this kind of occurrence of perioperative stroke in the first 72 hours. And as this patient have highest risk during this period, and they should be offered the best medical treatment if such kind of perioperative stroke occurs. These are the various references which I have used for this discussion. And thank you very much. I hope I have satisfied queries of all the attendees and delegates who have attended this webinar. Thank you so much.
So thank you, Dr. Manisha. I think you gave a very practical oriented talk on what to do, what not to do in patients who had a prior stroke or TIA. And you also, your last few slides very nicely summarized the key take home points of what to do in such patients. So I think that was a very comprehensive and practical lecture, and I'm sure that will be of interest to many people who are listening to you. There are going to be a lot of questions in the chat, but I just want to start off by taking the privilege of being the moderator for this discussion. Is that a lot of these patients are also have significant ischemic heart disease. They are all, this makes the situation even more challenging because you have to account for those issues as well, which of course was not the purpose of your current talk, but just to highlight that these sort of things also need to be considered when you're dealing with these patients. So I'll start off with some questions in the chat. Of course, there have been lots of compliments. It was an excellent lecture, which I completely agree with. So one question is post-stroke patient for TUR prostate surgery, for TURP. Should we stop the aspirin or can we continue the aspirin?
As I have already mentioned, sir, TURP is a closed space surgery. And this, if we see
Manisha,
the
could you hear me?
Yes, sir.
Am I audible, sir?
Yes, sir. You are audible. Yes, madam. You are audible.
Yeah. So if the patient is taking aspirin, but TURP itself is a high bleeding risk surgery. So it is always, and you cannot ascertain the loss or the bleeding after the surgery immediately, as it is a closed space surgery. So if the general condition of the cardiac status and the neurological status of the patient allows, it is always better to stop aspirin in a patient who is undergoing TURP.
Okay. Along the same lines, you mentioned that there is no evidence that either GA or regional anesthesia makes any difference in the stroke risk. But there is a small advantage, perhaps, in patients undergoing joint arthroplasties.
Yes.
Right?
Yes,
Now, in a regional anesthesia, now in this patient who is undergoing TURP, we often prefer spinal anesthesia because we're also looking out for the TURP syndrome and neurological issues.
Yes.
In this sort of situation, would you recommend spinal or GA, or it doesn't make a difference for TURP?
Yes, sir. If you take proper care of anticoagulants and antiplatelet agents, and if the coagulation profile is normal, and if the patient is properly breached on properly breached therapy, I think we can go ahead with giving spinal to that patient. There is no, but we have to properly manage the anticoagulants and antiplatelets before giving any regional anesthesia technique, especially central neuraxial block.
Okay. So the another question is, can we do invasive lines on the affected side in a patient with a prior stroke?
Invasive lines on affected side, I don't think. Yes, sir. Like putting it means that putting a arterial line mainly, or even a central line through a brachial artery. I don't think there is any risk associated with in putting a line on that affected side.
So you can go ahead if the side is.
Yes, sir. You can go ahead in putting
on the paralyzed side. If
yes,
it is
sir.
there, you can.
Yeah, that is what my opinion. If Dr. Joseph had to say anything, or even.
Go ahead and.
Sir, your voice is breaking in between.
Divatia, sir, your voice is breaking.
Venous line.
Sir,
your voice is breaking.
Voice is breaking, sir. Your voice is breaking.
Can you hear me, Dr. Mani?
Yes, sir. Now we are able to hear you. To add more to that answer, I would say that, sir, if the opposite limb is not getting operated, if there is no other option left, then definitely you can use the unaffected limb. But if the unaffected limb is there for surgical intervention, then you can use that.
Joseph, sir, you can also join. Can we start TAC lines in the affected limb?
See, if you have no other option, then you may go ahead. But there is no absolute contraindication. It could be a relative contraindication. But if you're having a doubt, it's best to avoid. If that's the only option available, then you can go ahead. See, most of the lines now we are passing it under ultrasound guidance. So there's absolutely no problem in that. And Dr. Divatia asked a question about the TURP case and the fact whether you can use spinal anesthesia. It's a very interesting question. Because, see, I think you have to take a decision based on each individual case. It depends on the size of the gland, how recent was the stroke, what was the dose of ecosprint that's going on. And now many of our cardiologists, they love to continue it and they don't like to stop it. Both the cardiologists as well as the neurologists, they would rather continue the ecosprint. So now the decision whether to give the spinal or to give general anesthesia will be individualized to that individual patient. Okay.
Okay. So I think there is a lot will depend on what the cardiologists and the neurologists want to do along with the surgeons and what we have to do. But I think
I would like to differ here with Dr. Joseph, because the duration of surgical intervention will not depend upon the, like even if it is a large size or gland, small size gland, it totally depends on the expertise of the surgeon as such. So if you take care of anticoagulants and antiplatelet drugs properly, you can go ahead with the safest anesthesia, that is the spinal anesthesia for TURP.
But
Yes, of course. If there is
either, right?
Pardon, sir?
There is no problem in giving G either, although our
there is no problem in giving
no,
J.
correct.
Yes.
So just coming to GA again, you mentioned, Dr. Manisha, that general anesthetics are neither neurotoxic nor neuroprotective
Yes,
as
sir.
far as this situation is concerned. So there are two questions, very interesting ones. Is what do you think about xenon? Do you think it is neuroprotective? And someone also, Dr. Paliwal also suggested that even dexmedetomidine may be neuroprotective.
Yes. Sir, frankly speaking, I do not know about xenon, whether it is neuroprotective or not, but dexmedetomidine has been found to be very useful, and we are routinely using it in neuroanesthesia, and it is a neuroprotective drug.
Okay. So you mentioned that you have to delay surgery. I think initially you said at least 1 to 3 months is a minimum that you should delay surgery for stroke.
Yes,
And in the final slide, you actually said 9 months would be the safest because that's when the stroke risk is almost equal to someone who has never had a stroke.
Yes, sir.
Someone who has had an embolic stroke, is it the same risk? And someone with an hemorrhagic stroke, is this risk the same? Ischemic versus hemorrhagic stroke.
Sir, it doesn't depend specifically. The risk of perioperative stroke do not depend on the kind of the previous stroke that the patient has suffered. Whether it's an ischemic or a hemorrhagic stroke, it hardly matters. But the perioperative stroke that will occur after the surgical intervention is usually mostly ischemic kind of type. So we have to worry about avoiding any kind of surgery within the first month, because that is the period where the incidence of perioperative stroke is high. So it doesn't matter on the class or the type of the stroke, whether it's a ischemic or hemorrhagic etiology.
Okay. So you also mentioned that you should at least maintain a MAP of 70.
Yes.
To prevent the risk of a ischemic stroke.
Yes, sir.
So if someone has had a prior hemorrhagic stroke, okay, it is also hypertensive and is on treatment and he has a surgery after that. Are there any recommendations for the BP targets that he should maintain in such patients?
So usually the recommendations that has been mentioned in the literature is about plus minus 20%. Do not allow the blood pressure to fall below 20% of the previous baseline values.
And
that has been given in the literature.
The higher upper limit that we should not allow the BP to go above something?
More than 160 millimeters of mercury. Systolic blood pressure more than 160. That has been also recommended.
A tight BP control in some of these patients.
Yes.
If someone has had an ischemic stroke in the post-op period or has had an ischemic stroke and requires TPA, what is the duration after surgery at which thrombolysis may be safe? And
I got it. How long after surgery we can use TPA?
And down to that question is, how do you treat a post-op stroke if it happens?
The first thing, it is very important to identify the post-operative stroke. As I mentioned, I have given the reasons that it is difficult to diagnose because these patients who have undergone non-cardiac, non-neurological surgery are in the general ICUs. So the staff should be trained to identify perioperative stroke. It should be detected immediately, and depending upon the urgent, the type of surgery which the patient has undergone, whether it is really safe to give the TPA for such kind of cases, has to be ascertained with consultation with the neurologist and the cardiologist. And definitely, if you have detected the stroke within first 4 hours and after the surgical intervention, and if the neurosurgeons and if there is a less bleeding risk, which depends upon the surgery which the patient has undergone, the patient can be subjected to the TPA, but you have to be worried about the hemorrhagic stroke that may develop in these patients who have suffered from ischemic stroke. So better to avoid TPA in this group of patients and start other line of drugs, because there is always a risk of hemorrhagic stroke in these patients if you start them on TPA. So that a combined decision has to be taken by the surgical team the neurosurgeon, the cardiologist, and the intensivist and anesthesiologist in such kind of patients.
So, Dr. Manisha, just to draw an analogy between a post-op myocardial infarction and a post-op stroke, right? So, it is said that myocardial infarction is not necessarily because of the classical mechanism of rupture of a plaque and a blockage of an artery.
Yes.
In the case of a post-op ischemic stroke, is the mechanism same? Is it more likely to be because an imbalance between blood flow or oxygen supply and demand, or is it often
It is a thromboembolic episode, sir. Most commonly it is a thromboembolic episode.
Usually in the setting of atrial fibrillation.
Yes, yes.
Okay. So then there may be some case for doing some anticoagulation or thrombolysis, but like you mentioned, I think thrombolysis you have to be very, very careful and sort of before you even think of thrombolizing these patients.
Yes, yes.
So someone has asked a question is, can we use ketamine for patients who are hemodynamically unstable and coming for stroke protocol? I'm not sure what they mean by stroke protocol, but in general, I think in neuro-anaesthesia, if patients have got a stroke or something like that, can you use ketamine in such patients?
Sir, ketamine, which was initially contraindicated in neuro-anesthesia, I think now it has become a friend of neuroanesthesiologists. And low dose ketamine, in a dose of around 0.5 to 1 milligram per kg, can be used if additional analgesic drugs are not available in that setup, like dexmedetomidine, like opioids, like narcotic, but it is not contraindicated at the moment in a patient in a general anesthesia for a patient who had this. But if better drugs are available, you should use them.
So I'll just go a little off track over here from stroke and then the role of ketamine, say in a head injured patient, right? And maybe Dr. Monteiro, Dr. Edward Johnson can also chip in, who's also hemodynamically unstable because of other trauma. And he's also got maybe an extradural hematoma or head injury. Can you use ketamine for induction of such patients?
So the induction dose is very high, madam. Cannot we go for a low dose ketamine in case of induction? So induction dose you have to avoid. What is your opinion, sir? Madam?
Sir, I personally feel that if the patient is hemodynamically unstable, is bleeding somewhere, maybe extradural hematoma, and also a bleeding in abdomen, which needs emergency exploration, and there is a hemodynamic instability, of course, ketamine will help in providing anesthesia. You can moderate a dose depending. You can use other additional agents like midazolam also along with induction agent. And ketamine can be used not only prior the common induction agent, the only induction agent. You can use other agents along with ketamine and can use as an induction agent for patients who are having bleeding in the abdomen or in the even extradural event.
I think that's
Dr. Divatia, just to add on to this, see in a trauma scenario, in an unstable patient, if the patient is unstable, etomidate is the drug of choice. If the patient is hemodynamically unstable, then the dose is 0.2 milligram per kg for induction. If the patient is hemodynamically stable, but you still don't want to use the other induction, then you can increase the dose to 0.4 milligram per kg. This is the recommendation by the ATLS. So if you have no access to etomidate, and then you insist you have to use in your scenario ketamine, then ketamine, which was much maligned and considered a foe, now can be considered a friend of convenience in that situation. And I think if you would use it along with midazolam, then you'll be able to use it.
So I think that's a very good message that both of you have given, is that ketamine is not something which is contraindicated, and in fact may indicate and may be helpful in certain scenarios, even if in the setting of maybe a head injury, because maintaining the blood pressure, cerebral perfusion pressure, and so on also take high priority, and maybe it's not as bad as it was made out to be some years ago. Okay, okay, just coming back to the questions. You mentioned Dr. Manisha actually covered cerebral autoregulation in stroke. So, but someone has just asked if you can quickly refresh us on what happens to cerebral autoregulation in stroke.
Yeah, the cerebral autoregulation is hampered in the first, the period that has been mentioned in literature is first 3 months. So you have to be very careful in first 3 months if you are subjecting the patient to anesthesia and surgery. The patients, the area is the area of ischemic stroke or the penumbra zone is, if there is a hypotension intraoperatively, there is a risk of occurrence of a stroke in that period. So you need to be very careful when you are anesthetizing a patient in the first 3 months. So as the cerebral autoregulation is very sensitive to the changes in blood pressure, we have to be it is important to avoid intraoperative hypertension.
Okay, thank you, Manisha. So now there's another, what are the recommendations of use of mannitol or hypertonic saline in the management of ischemic or hemorrhagic stroke?
Sir, that totally depends upon the MRI imaging, MRI films as well as the CT scan. If a stroke is big and if there is evidence of raised ICP, a midline shift or a mass effect, and the patient may need an emergency decompressive craniectomy, in such situations, there is a role of mannitol or hypertonic saline to decrease the ICP and to relieve the cerebral edema. As such, for the routine management of ischemic or hemorrhagic stroke, there is no role of anti-edema measures like mannitol or 3% hypertonic normal.
Nice, clear message you've given. You use it only if there is evidence of high ICP and maybe a mass effect.
Yes.
So is there any difference in the use of Dexmed in neurological patients compared to non-neuro patients? Because non-neuro, we see hypotension, bradycardia. So do you think it's a problem in neuro patients, or it's okay to go ahead?
Sir, the same complications are observed even in neurological patients also. So what I do usually, I combine these. I usually start. I do not give the bolus dose of dexmedetomidine because we have better drugs like propofol also for induction and other drugs. So I do not do usually bolus dose. That's what I do in the practice. I start them for infusion. For maintenance during the anesthesia, rather than giving the bolus dose, which has been said to be more critical as far as the bradycardia and hypotension is concerned.
I think that's a great practical tip. So avoid the bolus, the loading dose. Just start off with the maintenance sort of.
Yes.
Divatia, I'd just like to add here because I think quite a few questions about dexmedetomidine. Let me just say that dexmedetomidine is not an anesthetic agent. It is an adjunct. It will help you to reduce the dose of your anesthetic agent. So this must be very well kept in mind. You cannot equate it to an anesthetic agent. So don't please think that you can replace the anesthetic technique. And I saw one question there for one Dr. Priya saying that etomidate causes seizures. So how can you use it in traumatic brain injury? So to answer that question, which I saw in the chat box, etomidate doesn't produce seizures in every patient. In a patient who has already got some history of seizures, suppose you're already aware of it, it may, but it is a side effect. Now here also you must balance the risk versus the benefit of using etomidate in that situation. See, if just it is just mentioned that it can cause seizures, doesn't mean that it will cause in every patient. In that situation where the patient is hemodynamically stable and you need to use an induction agent, that is the question that first came, then it is the ATLS guideline to use etomidate in a smaller dose, 0.2 milligram per kg.
Okay. Now we are running out of time, but quick questions, quick answers if possible. Aspirin, should we stop even 75 milligrams or should we stop only 150 milligrams? 75, can we continue?
Low dose aspirin, sir. Whether it's the low dose or high aspirin, respect the bleeding risk of aspirin and better to stop it, in the indicated case if it is a closed space surgery or any other surgery with high bleeding risk.
Fine. Very crisp. A patient who has had a stroke within a month, in less than a month, and has now come for emergency surgery, let's say orthopedic fracture femur or something, can we give spinal anesthesia?
It is better to avoid. It is definitely better to avoid as the patient is on antiplatelets and anticoagulants. This is a semi-emergency surgery. You need to breach the patient. And when the patient had a stroke 1 month back or in a period of 1 month, better to give GA if there is no other contraindication.
Perfect. Okay. Any views on naloxone in stroke patients, Dr. Manisha?
Yeah, I do not have any experience. I have not used at all. I have not used at all naloxone for any of the case.
No, but what is the background to this question? Naloxone is stroke. What is the background?
I don't know. If he types the background, I'll get it for you. But
thank you.
You wanted to about monitoring in patients with stroke. Can you use NIRS to monitor the stroke risk, patients with stroke? And if you use NIRS, which side would you put it on? On the normal, on the
yeah,
effective side?
yeah. Sir, NIRS can be used. Definitely, it is if there is a risk, high significant risk of perioperative stroke. All this advanced neurological monitoring can be used, but I don't have any idea about which side. Dr. Joseph, can you help me?
Yeah, so
No,
no, that's an interesting question. Now, the NIRS is a very local monitor. Okay, it'll give you the cerebral oxygenation in that area where the probe is applied. Now, each probe, practically speaking, costs 7,000 rupees also. So, we have done the study in patients whom we gave a sitting position where we use the probe to check the oxygenation. Now, it will give you only that focal value. So, is it so you may, it's not a global monitor of the entire hemisphere. It is going to tell you a small localized picture. So very difficult to use it in that scenario.
Okay, fine. So I think we've run out of time for Dr. Manisha Katikar. So, but I think you've done a great job. You've very nicely told us about how to manage patients with a prior history of stroke or TIA. And you've given us very practical tips. And I think the ones which stand out are you should delay surgery at least for 3 months. And in the 1 month after a stroke, the risk is extremely high. Delay for 3 months, and 9 months. After 9 months, the risk is almost normal. So, but of course, you have to balance that against the risk of, against the urgency of the surgery, right? And then, of course, lots of tips on how to handle anticoagulants as well as antiplatelet agents, which these patients are invariably on. They often have atrial fibrillation. So that's the sort of other risk you have to handle. And you also mentioned that in patients, symptomatic patients with a carotid artery stenosis more than 70%, you should initially go in for revascularization, whether it's by endarterectomy or stenting prior to any major surgery. And I think you handled all the questions very well. So thank you very much, Dr. Manisha. And Dr. Johnson, can we
can
move
move
to the next
second topic? We can move.
Okay. So now the second talk is by Dr. Joseph Monteiro, and he is a consultant neuro-anesthesiologist and program director for DRNB Neuro-Anesthesia Intensive Care at the PD Hinduja Hospital in Mumbai. He has been trained in neuro-anesthesia as a fellowship at the Addenbrooke's Hospital in Cambridge in the United Kingdom. And he's been extremely interested in neuro-anesthesia intensive care. And he's had lots of other interests in teaching and training and in management. He's had multiple endowments and scholarships. And Dr. Monteiro is going to speak to us on a review of positioning and ventilation in neurosurgery. And I think it'll be a pleasure to listen to an extremely experienced and well-known neuro-anesthetist, Dr. Monteiro.
Thank you, Dr. Divatia, for that kind introduction. My topic for today is a review of positioning and ventilation in neurosurgery. Optimal positioning of the patient is vital to any neurosurgical procedure and a major responsibility shared by the entire operating room team. And anesthesiologists have a very critical responsibility for the positioning of the patients in the operation theatre. It's very important right now to know that when this position is being given to the patient, one must not be a spectator, but be an active participant in the whole process, because it requires a lot of meticulous attention to detail, which will ensure the good patient outcome. So what are the goals? It is patient comfort, patient stability and security, both during and after transfer onto the operating table, a balance between the optimal surgical exposure, minimal physiological alterations, and the patient well-being and safety, protection of the important structures like protection of the nerves by the padding surfaces, lumbar support and natural joint position, ergonomic ease of surgical and anesthetic team access for the theatre equipment. The general considerations in neurosurgery are most neurosurgical procedures are of a prolonged duration. The care of all the pressure points, identifying and protecting and preventing pressure point injuries, nerve injuries and spinal injuries are very important. The head end is normally elevated by about 15 to 20 degrees, which is essential to ensure optimal venous drainage during the intracranial surgery, and different types of endotracheal tubes may be required for the various positions that we use. The tubes should be very firmly secured over the face. Managing the airway in a neuroanesthetic scenario is very different from a normal scenario, because the head end normally is away from you, and once the patient is painted and draped, you have lost access to the head end of the patient to readjust your settings once the patient is induced. it's important to set careful goals both for your positioning. So careful patient selection is important. Selecting a patient for a particular position for a special surgery is a very good decision to be taken by the team before it is given. And sometimes it may be a little fancier position which your surgeon wants to implement, but you have to see this, what will be best for that patient in that scenario. The goal is always maintaining cerebral perfusion pressure and hemodynamic stability. So whatever you do, you maintain the cerebral perfusion pressure in a person who has got no neurological deficit. Maybe a cerebral perfusion pressure which is equal to the mean arterial pressure of around 60 is sufficient. But if a person has got some amount of neurological deficit, then 70. But in a person who's got chronic hypertensive, 30% from the baseline will be your target. You must optimize physiological functions, cerebral, cardiac, and respiratory. Optimize the cerebral venous drainage, maintain homeostasis. You also want to give a slack brain for good access to the surgeon. Access to the AV must be important, and access for monitoring is also important. So in case you have to reach out to your invasive monitors, and you must also avoid traction and traction injuries to the nerves and bony structures, and you must have ergonomic access to the equipment. So very often anesthesia and neuro-anesthesia is always they draw similarity between the aviation industry and anesthetists. It's a very good similarity, but I say not many of us will be having a pilot's flying license by the time we pass out. So I think I'll bring it a little closer back home. So I consider it something like driving your own car. When you are driving your own car, you have got a dashboard which you look at continuously the moment you start till you finish. And here you look at the airway, the breathing and the ventilation. You check for the circulation. You check for the devices where the monitors are well connected. You check for the extremities and the eyes, check the pulses, padding of the body prominences and eyes, and check that the eyes are free of pressure, especially in the prone position. Check the flows of your gases, oxygen and anesthesia. Gel pads for the padding of the pressure points. Head elevation, as I mentioned earlier, with a 2-finger breath between the chin and the nearest bone. Intravenous access, check your lines, extensions, and infusions, especially if you're using total intravenous anesthesia or a PCI technique. Check your joints whether they're appropriately positioned. Now, the take-home message I want to give from this slide is, it is not that you look at it once and that's it. You have to keep on looking at these dials, keeping on doing this A, B, C, D, E, F, G, H, I, J throughout the procedure. It's not that you have given it once, because intraoperatively there can be a scenario where one of these things are affected and you may have to revisit that situation. Now, I've been given this talk by Dr. Edward Johnson. He says, review the positioning and the ventilation, quite a vast topic. I will sort of simplify it to just 3 types of surgeries: supratentorial surgery, posterior fossa surgery, and spinal surgery, because this is what we normally commonly do. The effects of positioning can affect the respiratory system, the cardiovascular system, the musculoskeletal system, peripheral nerves, ocular. So there can be thromboembolic events, and there can be other systems also involved. So the preoperative conditions are, you check for the history of syncope and associated disease, if it affects neck movement and head and neck movement. Check the physical examination for morbid obesity, dehydration. These patients usually are on diuretics, and so they may be already vascularly compromised before they're taken up for surgery. Check for every abnormalities of joints, history of rheumatoid arthritis or some abnormal joint position. So the types of craniotomies are the 5 classical surgical approaches of craniotomies are frontal, temporal, occipital, parietal, and posterior fossa. And these are the sort of craniotomies that are performed: anterior parasagittal, frontospherotemporal, subtemporal, lateral suboccipital, midline suboccipital, and posterior parasagittal. You notice here the patient is fixed on a head clamp. Now with neuronavigation techniques, we want the patient to be absolutely rock steady. So we have the patient fixed in a clamp. Some surgeries are also done on a horseshoe, but there may be slight movement there in such cases. Maybe some relatively non-invasive surgery, a smaller procedure, a minor procedure, moderate procedure may be done on a horseshoe. Positioning for supratentorial surgery, it can be supine, lateral, or prone, depending upon the access of what the surgeon wants. The anesthesiologist and anesthetic equipment are positioned to the left, at least in our scenario, and allows unimpeded surgical access to the scrub nurse, the assistant, especially for the right-handed surgeon. The position and the fixation of the head, it is normally fixed in pin holders, the Mayfield clamp, the keys, or the Sugita clamp. It can be, as I mentioned earlier, horseshoe or donut headrest also, or you can have a foam and gel head support depending upon the scenario in which you're working in. One of the most important part of the neuroanesthetic technique is that attenuation of the sympathetic response, which can also, not only at the time of induction, laryngoscopy, intubation, it also comes during the time of positioning as well as during final head clamping. So various techniques, the analgesic technique is the most commonly used. We can also use a scalp block with local infiltration, which will decrease the amount of opioids that you need to use. The depth of anesthesia should be monitored. It's important to have a depth of anesthesia monitoring going on. And sympathetics, which are also used, I prefer short-acting drugs like esmolol. Labetalol also can be used, but must bear in mind that its half-life is longer than esmolol. These are various aids which are available, which can make it easier for you to position a patient well. Now, depending upon the scenario in which you work in, either you have access to these aids, they're very good for you. If you don't have access to it, then one must, as most Indians are very good at, innovating, you probably can make something locally so that it has the same effect, which is a little more cost-effective and ergonomically designed. Head and neck positioning, head rotation, hyperflexion, hyperextension, and lateral flexion. You must be very careful in this when you're giving the head position, because you can lead to brainstem and cervical spine ischemia. You can get quadriparesis, quadriplegia, and cerebral infarction. Mid-cervical quadriplegia is common in the sitting position in a hyperextended head. So the patients who are at risk are present with osteophytes, arthritis, vascular atherosclerosis, obesity, patient who is hemodynamically unstable. You must not rotate the head too much, not more than 45 degrees. For more rotation, a roll of pillow must be placed under the opposite shoulder, and must always maintain a 2 to 3 finger breadths thyromental distance during the neck flexion. So even after you have given it, sometimes the tube may migrate after you give the position. It's very important to auscultate the patient thrice. One is before the induction, so you get at that point understanding of what is the patient's lung mechanics. Then you do it after intubation. And I also obsessively do it after head positioning, because if it is the tube has migrated for some reason due to the positioning, you have to correct it at that stage. No surgeon is in such a hurry that he's going to go ahead with the surgery without repositioning the patient. We always not only check the auscultation, we see the airway pressure and make sure that the airway pressure is also well, as per what is your requirement, because high airway pressures are transmitted to the intracranial pressure, and it may lead to a difficult tight brain intraoperatively. So important, spend some little time soon after induction, soon after positioning, and auscultate once again, make sure your tube is well secure as well as it is well positioned. Supine position, the most commonly used position, also called the dorsal decubitus position, is used for frontal, temporal, parietal craniotomy approaches and most commonly performed in this position. For midline and subfrontal lesions, the head is kept straight but extended at the neck to allow the frontal lobes to fall away from the base of the skull with gravity. More posterior and paramedian lesions may require the head to be flexed at the neck. For a right or left-sided lesion, a soft roll is placed under the ipsilateral shoulder so that the head may be turned to the opposite side without much neck rotation. The head is secured using a 3-pin head holding device. And the supine position is also used for anterior cervical procedures and occasionally as a part of the 360 fusion of the lumbar spine. So this is an image now of the patient lying on the table, supine position. And the indications, most of the cranial procedures, anterior cervical spine, as I mentioned, anterior approaches the lumbar spine, carotid endarterectomies, brachial plexus surgeries, endonasal pituitary surgery, and endoscopic third ventriculostomy. Once again, just to have a closer look at the occiput, which is raised on a small pillow here, the scapula, the position, arms and elbows, the thoracic vertebrae supported. And you can see this roll, which I like to place below the knees as well as below the ankles. The essentials of the supine position, the arm should be comfortably positioned. Normally, it's by the side of the patient. The bony point should be padded to protect against brachial plexus and ulnar nerve injury. There should be no pressure on the heel. There should be no pressure on the occipital scalp. And careful position of the head in the presence of cervical spine injury is important. And we use auto compression stockings to prevent thromboembolic disease. The arm position, you can see here on the arm board. If it is on an arm board, then it should not, the abduction should be limited less than 90 degrees whenever possible. The arm is supinated and the elbow is padded. And if we do it this way, the arm is stuck by the patient's side in a neutral position with the palm to the hip, the elbow is padded, and one needs to ensure that the arm is supported. Now, here is a very interesting thing. Very often, your surgical assistant may want to adjust this position so that he will be able to assist the patient surgeon better. But one must make sure that what we are looking out for is the patient safety. So I don't compromise on the position of the hand, whether it's abducted or not. It may be just thodi der ke liye de do, it doesn't work with me. So you have to make sure that you look after the patient because the patient is anesthetized. Varieties of supine position: supine with the head low, there's a Trendelenburg position, and supine with the head up, there's the reverse Trendelenburg position. It helps, and the lawn chair position. The risk of the Trendelenburg position is in a patient with raised ICP, it can also worsen the intracranial pressure. They can have edema of the face, conjunctiva, tongue, and lead to post-operative airway obstruction. The reverse Trendelenburg position, decrease in the CPP, decrease in mean arterial pressure, and chances of venous air embolism. One important thing is if you've given a Trendelenburg position for a long time, I always check the hemosis of the mucosa of the conjunctiva. So that will give us a general inkling into what will be, whether the presence of airway edema is present at the time of extubation. So have a look at it. In case it's edematous, the conjunctiva, then you go a little even more carefully at the time of the extubation. You can do the leak test before you extubate the patient. The lawn chair position is a modified supine position. It's a contoured supine position, and some people call it beach chair or lawn chair. The trunk thigh hinge is angulated approximately 15 degrees, and the thigh and knee hinge is angulated a similar amount in the opposite direction. The patient lies comfortably with hips and knees flexed gently. It's a comfortable position for surgeries for prolonged duration. And as I mentioned, the elevation of the occiput on a small pillow raises the head above the level of the atrium. Here's another small, we also prefer this position. The physiological responses to the changes in the position from erect supine to on circulation are the systemic circulation. The body maintains the blood pressure and tissue perfusion through the pressoreceptor reflexes, that's the main bridge reflex, which are autonomic reflexes. Then the entire body is close to the level of the heart, and the influence of the gravity on the vascular system is minimal. Thus, hemodynamic reserve is best maintained. As the head is tilted high or low, the effects of gravity on the blood flow in the head become quite significant. The autonomic reflexes will be depressed by disease, injury, as well as the anesthesia. On the cerebral circulation, autoregulation of blood flow is a normal response. The head lobe position increases the venous, intracranial, and intraocular pressures. In the presence of raised intracranial pressure, head down tilt can provoke or intensify cerebral edema and dangerously increase the intracranial pressure. In the elderly patients or in the autonomic nervous insufficiency, the compensation may be altered, resulting in cerebrovascular ischemia. So this now a little practical point here is in case you're putting a central venous line with a patient who's undergoing, let us say, an aneurysm surgery. So and you can see preoperatively that the intracranial pressure is slightly raised because of the subarachnoid hemorrhage. Don't give a head low. Head is in the neutral position. Now you're using the ultrasound. Use the ultrasound to locate the thing. Please, in such a patient who's slightly compromised, who's borderline compromised, just that small tilt which you give so as to be able to pass a central line may not be a good idea at that stage. Now, effects on the respiration. So head and now see Dr. Edward has told me to speak a little on the ventilation as well. So head up tilt, the visceral weight shifts away from the diaphragm and the ventilation is enhanced, improving FRC, reducing the peak airway pressure. In turn, decreased central venous pressure results in better cerebral venous drainage and decrease in the intracranial pressure. The head down tilt decreases the FRC and pulmonary compliance. Respiratory alteration, you have to maintain the ventilation and perfusion. In a spontaneously ventilating patient, the work of breathing increases. In mechanically ventilated patients, the airway pressure may be higher to ensure adequate ventilation. And you must be aware, as I mentioned earlier, the displacement of the migration of the endotracheal tube. So very often I'll just say that, once you're intubating the patient, I always do a manual inflation of the lungs for lung recruitment at that stage. And sometimes as the surgery goes on, you may have some collapse of the lung in a corner. So then intraoperatively, it will be very difficult for you to access and ventilate the patient intraoperatively if the procedure is going on. So do the lung recruitment soon after intubation. The complications of supine position are postural hypotension depending upon the patient's vasocompensatory mechanisms. Postural hypotension may be seen in a head elevated position. The pressure point reaction, weight-bearing bony prominences can produce ischemic necrosis of the overlying tissues unless proper padding is applied. You can get pressure alopecia due to prolonged compression of the hair follicles, which may produce hair loss. And alopecia may not occur several days to weeks after the procedure. So suddenly you may get a surprise visit in the follow-up. Backache, especially in patients who have a herniated intervertebral disc. Brachial plexus neuropathy and peripheral nerve injury is not something very uncommon, so please be aware. And venous air embolism in a head elevated supine position. I must mention now, remote cerebellar hemorrhage is a very rare complication following supratentorial surgeries. That is due to direct venous obstruction in relation to head rotation and neck extension in frontotemporal craniotomies in a supine position, which could occlude the jugular veins and lead to venous hypertension. So other mechanisms proposed are surgeries entailing the removal of large amount of CSF and supratentorial cerebral contents. The risk factors are hypertension, intraoperative opening of the cisterns, and postoperative CSF drainage. Now with this, we move on to the lateral decubitus position. You can see in this position, the flexion of the lower leg, padding between the legs, and proper support of both the arms. So here, in this image on the right, you can see without the padding and with proper padding. The effect. So it's very important that you give the position and make sure that there's you put the pillow between the legs and support the ankles, and there's a roll below the shoulder here. So that makes sure that the position is given well. The CNS, it causes raised CVP, ICP, and IOP in the lateral position. In the respiratory system, the abdominal viscera pushes up the diaphragm, resulting in decreased FRC, decreased pulmonary compliance, and VP mismatch. In the CVS, there's increased cardiac output, redistribution of the blood volume, and volume overload. The GI, the stomach moves up, so the chances of aspiration are high. You can, because of loss of lordosis, you can get backache. Peripheral nerve injuries are also common because the hand that is below gets compressed. So the ulnar nerve is the most common nerve that's injured. Here's how we do it. So you can see a patient, there are two images here, where you can see the patient is in a lateral position. What we do is we support the arm in an arm pouch, which is slung and fixed. We have put a white leucoplast on the palm, and that is fixed independently onto this stand. And you can also see that I prefer to take the lines on the arm that is above, so it doesn't get compressed. The pulse oximeter also will be on the arm above, radial arterial line also on that hand, and my peripheral lines also will be on the hand that is not dependent. Because once it gets compressed, then it's very difficult to intraoperatively manage this situation. You can see here the transducer at the level of the heart. Make sure that you keep the transducer at the level of the heart. Okay. Here you can see another picture. A little close up. Patient neck is free, eyes are padded, and even after I put those 3 fingers between the chin and the mentum, I also do another little practical point. I put in a red rubber catheter to go through the endotracheal tube to do a suctioning, just to see whether the tube is patent. So that's another very simple thing which you can do. Do it, and especially in this lateral position, I do this. See here, the access to the more axial structures. It is good for ventilation in obese kyphotic patients. Diaphragmatic exertion is better, decreases the intraabdominal pressure. It's used for temporal skull base and posterior fossa surgeries, lateral approaches to the cervical spine, transthoracic and retroperitoneal approaches to the thoracic and the lumbar spine, and for lumbar peritoneal and syringoperitoneal shunts. You can see this patient in a graphic representation. The precautions here are padding on the bony structures, fixing the regions susceptible to by pressure, abrasion, or movement. Mild head up helps to help venous drainage. Knees are mildly flexed to avoid lumbosacral injury. The pulse should be monitored, as I said, in the upper limbs. Compression of the neurovascular bundle in the axilla can occur, so which may affect your arterial and the pulse oximetric trace. The physiological changes in the lateral position are in a patient who is mechanically ventilated, the volume of the dependent hemithorax is reduced by the lateral weight of the mediastinum and the disproportionate cephalic pressure of the abdominal contents on the dependent lung. So it favors overventilation of the non-dependent lung. At the same time, the pulmonary blood flow to the underventilated dependent lung increases owing to the effect of gravity. Consequently, there's a clinically significant ventilation perfusion mismatch, especially in the presence of pulmonary disease and also during prolonged surgery. Now, see, if you have a absolutely person with normal lungs and you do the lateral position, may not affect you. A patient with COPD or a patient who's already got some respiratory compromise, it may affect you. And in these patients on the lateral position, as I mentioned, that lung recruitment maneuver, I do it every 1.5 hours because there's a lot of shunting and you take some little time off. It's almost like doing a thoracic anesthesia case. So you take little time off, tell the surgeon to wait for some time, do this thing and check. And of course, regular blood gases are done. Physiological changes in the lateral position. The lateral decubitus position is preferred during pulmonary surgery and one lung ventilation. And the minute ventilation of the dependent lung is usually increased when the non-dependent lung is collapsed. So the head down tilt, the lateral position worsens the pulmonary function till further increasing the sun fraction. So this is, we all know the west lung zones. You can see here in the uppermost zone, the alveolar pressure is high, so it's well ventilated but poorly perfused. And as you go lower, the ventilation gradually decreases and the perfusion also it increases. The cardiorespiratory effects are respiratory increased VQ mismatch. The non-dependent lung is poorly perfused, well ventilated, and CVS very minimal changes. MAP and HR are unchanged. Now this is a little modification of the lateral position, the park bench position. I don't know who sleeps in a park bench in this position, but anyway, this is the name that they've given. It's a modification of the lateral position. It gives better access to the posterior fossa as compared to the lateral position. And the upper arm along the lateral trunk and the upper shoulder is taped towards the table. The lower extremities are slightly flexed and a pillow is placed between the leg with a reversed end limber position. Once again, you see here the pressure, padding, securing the lines, and lines are in the armrest above. And we tape the eyes. I put a gauze piece mouth pack to suck up the secretions, because otherwise secretions may pool and it may affect. So I normally put it for all my cases. So once you do a proper suction, I put in a mouth pack, not necessarily a throat pack, and that is taped in place so that it sucks out the secretions which may affect the sticking of your endotracheal tube. Complications are prolonged surgery in patients with pulmonary disease can cause significant ventilation perfusion mismatch and increase airway pressure. The lateral position with neck flex can cause facial and tongue edema due to decreased venous drainage of the facial veins. They can have injury to the dependent eye and ear avoided by careful turning out from the supine to the lateral position. In a patient with arthritic cervical spine, worsening of the neck pain can occur. An unstable cervical spine can be intubated while awake and gently turned to the operative position, while repeated neurological checks to detect the development of a positional injury. Next, we come to the much maligned sitting position. So whenever people speak of the sitting position, the first thought that comes to their mind is venous air embolism and sucking or aspirating the central line, and a lot of air is coming into that. So little philosophically speaking, I always believe, there's a little good and bad in everyone. So one must not focus too much on the bad, try to focus a little on the good, and try to reach some sort of a compromise. You can reach a nice balanced approach to the situation. So you can see here there are many articles on the sitting position when we were all doing our training. Sitting position in neurosurgery, a critical appraisal by Professor Cunningham from the UK. And then they were critical to the extent that it was given up in Britain. And even in the United States, it was given up because the cost of litigation was too high. And then, so several generations of anesthetists, I think, were not even trained in the sitting position, and so also as neurosurgeons. So it was Dr. B.K. Mishra who wanted to revisit the sitting position. And so we decided to revisit it and try to do it in a better way, so that even if you are not trained, you should be able to do this position in a patient who is requiring it. the patent foramen ovalian neurosurgery, a systematic review, another article where sitting position with patent foramen ovale is a contraindication because of the shunt. And so now gradually the things are moved in this direction. So we have this Gail and Leslie from Australia who published Anesthesia for Neurosurgery in the Sitting Position. This is in 2004. And they have said here, they reviewed the advantages, disadvantages, and they said it offers many advantages in terms of surgical access for posterior forceps and cervical spine surgery. And these advantages should be balanced. So once again, a big Turkish group has done neurosurgery in the sitting position, a retrospective analysis of 692 adult and pediatric cases. And me and my colleagues at Hinduja, we reviewed the sitting position. And we felt that it has, since its inception, the use of this particular position has been contentious due to its risk-benefit analysis. With improved microsurgical equipment and surgical and anesthetic technique, as well as advanced monitoring techniques to assure patient safety, we concluded many centers are revisiting the sitting position for its potential benefit. So the physiological changes are the pressure gradients develop as the head is raised above the level of the heart, the blood shifts from the upper body towards the feet, atrial filling pressures decrease, sympathetic tone increases, and parasympathetic tone decreases. The interthoracic blood volume decreases as much as 500 ml. Pulmonary vascular resistance can double, and left atrial pressure falls more than the right atrial pressure. The cardiac output decreases by 20 to 40%. Stroke volume decreases by 50%. Heart rate may increase by 30%. Cerebral blood flow decreases by 20% with a head elevation. And the renal blood flow also decreases as much as 30%. GFR can also decrease. So in an anesthetized seated patient, the mean arterial pressure should be measured at the level of circle of Willis, as is the more reliable indicator of the cerebral perfusion pressure. The physiological changes in the respiratory system in an upright position, since the bulk of the abdominal viscera falls off the diaphragm, less pressure is required to ventilate the lungs during the anesthesia, and the functional FRC increases, as also age-related increases in shunting. I prefer the sitting position. I think it's one of the best positions for the respiratory system because the diaphragm moves, the excursion of the diaphragm is very good. The lungs expand completely. So I feel it is a good position for the respiratory system. These are the various types that were described. So now you see, it may not look very different to you all, but you can see here the sitting position is classic. And here you can see the Mayfield support. Now, if you notice here, the Mayfield support is fixed to that part of the table that is supporting the thigh. Now, in case you have to do a sudden change in position or you have to do some CPR, very rare, but anyway, if you have to do it or you change the position intraoperatively, this is not a very convenient setup to do the changing. So now, hence, the Mayfield support now is modified, it's fixed here. Can you see here? This is the part supporting the thorax of the patient. So in case you have to suddenly change the position, it will be easier. And this is another further modification. You can see the base of the table, how it is changed. So you can move the patient or change the position even more conveniently. The pressure points are the scapula, ischial tuberosities, back of the knees, and the calcaneus. The sitting position has been used to access CP angle, cerebral hemispheres, fourth ventricle, and the pineal gland. It was more commonly used in the past for posterior cervical spine procedures. The relative contraindications are intercardiac defect with the right to left shunt, pulmonary AV fistula, severe hydrocephalus, functioning atrioventricular shunt, significant hypovolemia, myocardial dysfunction. It's very important to know that, as I mentioned in the earlier part, for every situation, you measure the risk versus the benefit to the patient. And you individualize that positioning, the choice of the position in that individual patient. Very difficult to give a cookbook recipe and give a statement saying that, it is not good or it is good. You just see in that situation, maybe in that situation, it will work well for your patient. So this is positions as we give it in our hospital. Initially, we started off with a little more flexion here in the thigh, but we have decreased that as we went along. You can see here, head fixed. Patient has got the thromboembolic stockings going. And there are some videos I'll play for you. It should be given very carefully. So as I mentioned earlier, that we also put these oximetric probes in some of our patients to check Because very often, as you're giving this position, not only you look at the hemodynamics, the pulse oximetry will show a normal 100% saturation, but the perfusion of the cerebral perfusion may decrease. So you do it well in coordination with the surgeon. And now at the time of the health clamping, you may have to give an additional dose of something to make sure that the blood pressure is well controlled. See the number of people involved. Now see, each of these team players know their job very well. It is not some new person who's come. And these are not the attendants. These are all young neurosurgeons. So that is the sort of importance you should give to it. You cannot regulate it to somebody who has never been involved in this thing before. So you must know your team well. You must choose your team well for proper success. And now, once again, very carefully, you're giving the position, keeping a watch on the hemodynamics, making sure that the patient is adequately filled. I like the use of pulse pressure PPV nowadays because it tells you not only the blood pressure, it tells you the volume status of the patient. And sometimes you may even have to give a vasopressor. Don't hesitate to give a vasopressor to maintain the hemodynamics. My colleague here is adjusting the arterial line transducer, so that is at the level of the circular villus, as I mentioned. So the endotracheal tube, the problems with it, you can kind of hyperflexion can lead to kinking of the tube. Airway compromise may lead to increased airway pressure. ICP may be also increased. So as I mentioned before, once again, I'm saying 2 to 3 finger breadth between the chin and the nearest bone. We also use the armored, the flexometallic tube in patients of sitting position, prone position, depending upon the scenario. Now, much is spoken of airway, this intracranial pressure, but not many people speak about this airway, increased pulmonary, the airway pressure. Once you're ventilating the patient, what we choose is a little lower tidal volume, the so-called lung protective strategy, low tidal volume, slightly higher rate, and the PEEP of 4. That's what I use for all my patients. So you must reach a situation where you also keep a close watch, not only on the saturation and the end-tidal carbon dioxide, airway pressure should be monitored throughout. So that can lead to direct effects on the intracranial pressure. It's something which is not spoken about much. Here, this is the use of the sitting position in pediatric patients. It works very well in them too. And not only it gives good surgical access, so I think everybody should be trained in it, and it is not so bad as it is said it is to be. Once again, here, this small children sit down. So it's a well-given sitting position requires a lot of teamwork and coordination. Now, the advantages are good surgical exposure, improves respiratory mechanics and ventilation, as I mentioned, better airway access, great surgeon comfort, and possibly reduced blood loss. The disadvantages are risk of venous air embolism, which everybody speaks harps about, pneumocephalus, potential hemodynamic instability, sciatic nerve injury, swelling of the face and tongue, and as I mentioned earlier, mid-cervical quadriplegia. So this is the monitoring what we do. Once again, as I showed you, we see the spirometric loop also there, and we keep a watch on the airway pressure. Now, which are the monitors for venous air embolism? In terms of decreasing sensitivity, you can see here, TE, Doppler, PA pressure, which we normally uses, cardiac output and blood pressure. And here you can see here, which are those which decrease and increase. As the amount of volume of air increases, what are the changes that can occur? Venous air embolism may occur, but one must know it also depends on how much air is entrained, where is it entrained, and what is the volume and the speed of entrainment. So you also have to look at the source, the amount, the channel where it's trapped, and whether it is reaching the right ventricle or not, and or it's entering into the pulmonary circulation. Every micro drop of air that enters will not needlessly cause prostration and circulatory collapse. We use the TE probe for our patients. It has got the highest sensitivity. It can detect up to 0.02 ml per kg of air. It is the limitation is invasive. It requires expertise. But I think now all of us use the TE, and we all use the echo intraoperatively. So it is constant vigilance is required, but that should not be a limitation. Precordial Doppler is also described with a high sensitivity, 0.05 ml per kg. The limitations in obesity and COPD. And what I have found is it's very difficult to fix that probe. Technically, it's very difficult to fix that probe onto the chest. PA catheter only described in theory, but unable to do much of aspiration through it because of a small diameter. End-tidal nitrogen, not widely acceptable. You could have a huge equipment for it. EtCO2 is the traditional thing that's used, moderate sensitivity, 0.5 ml per kg. So it may be definitely be later than picked up in the TE. It's not very specific also because there are many other causes of the fall in EtCO2 intraoperatively. Saturation low is a very late indicator, and that too is not very specific. So classically, what people use is the end-tidal. So a fall in the end-tidal. But now what happens, as I mentioned, is not specific. It may cause, there may be a decrease in the end-tidal carbon dioxide because of hypovolemia. I don't want to get into that. But it gives you an indication, definitely. Now, why does this cause a fall? Because the air has nitrogen. That nitrogen, as you can see here, it causes a sort of an airlock in the pulmonary circulation and no CO2 exchange occurs there. This is very simplistically put, but this will give you an idea because so then when the patient is expiring CO2 and nitrogen. And hence here he's getting only CO2 and no nitrogen. ECG also has some changes that mild ST segment elevation, some TB inversions, some you can see the but non-specific again. How do you prevent it? By volume loading, or you at least maintain normovolemia, I'll say. So you keep the CVP at about 10, 8 to 10. You use, they have described G-suit, but we use auto compression stockings. PEEP, I use a physiological PEEP about 4 or 5 centimeters. See, the use of PEEP is very good. Some people may argue about the effect of PEEP on intracranial pressure. But what happens is when you give PEEP, the gradient between the exterior and the venous system is decreased. The venous pressure will go up. And hence, if the air is entering, less amount of air will be entering into the vein. Now, deliberate hypoventilation, we don't use it. Previously, traditionally, maybe they were using the spontaneous respiration when they had no other monitors. And then the last option is choose the alternate position. But please don't jump to that immediately. So if it is not possible, and there are, as I mentioned, if the patient is not fitting into the scheme of things, then you can choose another position. So what happens? What do you do when you encounter venous air embolism? You alert the surgeon. He floods the surgical field with occlusive pads and bone wax, general compression of the internal jugular veins, one at a time. So when you compress the jugular vein one at a time, the venous system on that side, the pressure will go up, and they'll be able to see whether that air is being entered on that side or not. Don't press both at the same time. Changing the patient's position when the entrainment lower the heart. That's only in severe air embolism, which we have not done. And you can aspirate the RA catheter, discontinue nitrous oxide if it is used. I don't use nitrous oxide. So nitrous oxide will increase the size of the air bubble by 33 times. So it's better not to use it, especially in a sitting position. Supportive treatment is 100% oxygen, inotropic support, volume administration, CPR if required. I'll just show another quick video here of, you get what they call the classic snowstorm appearance. You can see here the right atrium here in this image, what they call a snowstorm appearance. And I'll just show you one video here. You can see this. Okay, so when the air is getting entrained. Now be a little away. If you're giving mannitol at the same time, because that mannitol also can give you this appearance. And suppose you take a flush and flush in air, there will be some micro bubbles in the flush. So if you're giving some volume suddenly and you just see this, it may be you injecting something in. It is not necessarily the air is being entrained on that side. Now, I would like to say that there is a scale called the Tübingen scale, which classifies the amount of venous air embolism. So not every case of venous air embolism is a grade 5. The grade is 0, 1, 2, 3, 4, 5. And it's showing you now air is seen on TE. In 0, nothing is seen. And as you go progressively downwards, at grade 5, you can see a lot of air is being seen on the microbubbles are seen on TE. The EtCO2 decrease in 0 and 1 is none. And as you go forward, less than 3 millimeters, more than 3 millimeters, and more than 10 millimeter fall. And the mean arterial pressure, you can see here, it doesn't occur till grade 4. A CPR is required in grade 5. Arrhythmias also are seen in grade 5. And you can see in grade 4 also the heart rate change will be more than 40%. So let me tell you a take-home message from here. There may be venous air embolism, but everyone is not a grade 5 or grade 4 or even a grade 3. Now, as I mentioned, we did this effect of sitting position on and use of cerebral oximetry. So you can see here now, we're monitoring both the sides and it's giving you an indication. The saturation is 100 and the cerebral oximetric value is 50. So we kept a cutoff that if it goes to below 50, then we use vasopressors and increase the oxidation and try to maintain it. But we did this study, and it goes to show that you can use it in conjunction and it help you to give the position carefully, more carefully, because you're getting an objective number on which you can go. Otherwise, you're going a little blind. You got only the pulse oximeter and the hemodynamics, but this gives you a new way of monitoring the cerebral oxygenation. The anesthetic technique in this position, I think I'll go in the use of nitrous oxide is controversial, so I don't use it. If you are going to use a sitting position, better don't use it. There are better anesthetic agents available now, and airway can have partial obstruction, kinky and obstruction, endobronchial migration, facial and tongue swelling. These are the complications described. These are the cases that we did. You can see it started out 2011 and gradually picked up. We do a lot of skull-based surgery, and you can see it. Then came the pandemic, so it decreased, and then gradually, so it's going on. So 22, I don't have this year's data, but anyway, complications 8%. Described in literature as 25-40%. Our incidence was 8%. 8%, and that too, we are talking about using the TE probe. We had one facial and tongue swelling, we had one case of quadriparesis, foot drop, and one temporary blindness which recovered. Now it's very important. I also say in an elderly patient, I think more than 70, with some vascular compromise, triple vessel disease, or on medication, or as Dr. Manisha has spoken about stroke patients, then I think you avoid doing those patients in the sitting position. Now, next we come to the prone position. The indications are posterior fossa lesions, ideally suited for midline lesions in the cerebellum and for exposure of the fourth ventricle. Midline and paramedian occipital low lesions are best dealt with in this position. And the induction and intubation is done on a stretcher. The tube should be well secured to prevent dislodgement and requires coordination of the entire operating room staff. As I mentioned, ETT and ventilation are reassessed. So these are various things described in the literature. It can, if there's insufficient abdominal bolstering, you can get venous congestion and increased brain swelling and increased venous bleeding. So hyperflexion and kinking of the endotracheal tube is possible. Increased abdominal pressure, which resulting in increased airway pressure, as again I'm mentioning, and it can lead to airway and ventilation compromise. Now, as I mentioned, it can be done either with pins or with the horseshoe. There's a thing called a mirror system which monitors of the eye and the airway with a plastic mirror so that you can see that it is secure. The Wilson frame is also described. This is more for spine surgeries. You're obviously doing a lot of spine surgeries. So the Superman position with the arms may be positioned next to the patient's head on arm bones. The physiological changes of the circulatory system. The hemodynamic reserve is maintained. The head is below the level of the heart, so venous congestion of the face and the neck becomes evident along with conjunctival edema, as I mentioned earlier. And in the respiratory system, the pulmonary function may be superior to the spine or the lateral position if there's no significant abdominal pressure. Now, this is a very big if, and the patient is properly positioned. Pressure on the abdominal wall forces the diaphragm kephler, reduces the compliance, and requires higher inflation pressure during positive pressure ventilation. This is what happens more commonly. Next, we come to the Concord position, which is a modification of the prone position. The head is higher than the level of the heart, 3-point fixation. Head flexed with the extension of the thoracolumbar region. The occipital and transtentorial and supracerebellar and infratentorial approaches. The complications are chin necrosis, obstruction of the cerebral venous outflow. This is another position called the Concord position, increasingly popular for surgery in the posterior fossa. Head supported in a 3-pin head holder. Conjunctival edema is less likely. Lower risk of air embolism. And resuscitation requires restoring supine. The Sphinx or the C-line position also described, first devised by Suzuki around 1983. It is used in some cases, especially I think now, removal of falcotentorial meningiomas, and also in cases for craniosynostosis in centers doing it. The hyperlordotic prone or the C-line position is also a modification of the prone position called a C-line position for approaching pineal region in patients who cannot tolerate the sitting position. And this is a bunny crouch position for posterior fossa surgery in infants, wherever severe hydrocephalus in whom sitting position is contraindicated. It gives access to the apex of the fourth ventricle and may be achieved with this approach. Complications of the prone position, chance of endotracheal tube migration is more common in the prone position as compared to the lateral and the supine position. Facial and tongue edema, as I mentioned. Now, I must mention quickly about postoperative visual loss when I'm speaking of the prone position. So the etiology is decreased perfusion pressure, decreased blood pressure, and increased venous pressure or large vessel occlusive disease. And it's one of the most common cause of litigation in the US. In fact, you normally you inform the patient preoperatively when you're giving the prone position that the chances of postoperative vision loss are a possibility. What are the types of thing? Can be anterior or posterior ischemic optic neuropathy. Anterior optic neuropathy is caused by occlusion or hypoperfusion of the anterior optic nerve, heads by the PCN, usually presents with sudden loss of blindness, which is painless, vision loss with visual field defect. It is more common in cardiac and vascular surgery. PION results from infarction of the optic nerve posterior to the lamina, is associated with high venous pressures in spine surgeries. The other causes of blindness are the CRAO, cortical blindness, and PRESS. On a fundoscopic examination, the edema blurs the optic disc margin in AIOL, and the PIOL, it is the normal optic nerve and retina and macula. So what can we possibly do? Keep the head at the level of the heart. I think in surgeons who take a little longer time and with very steep head-low position, this is more common. Use colloid and crystalloid to maintain the intravascular volume. Consider a staging procedure if the surgery is going to take more than 6 hours. And I think nobody uses controlled hypotension anymore. But in case you do that, see the procedure, whether it's cerebral perfusion pressure or spinal surgery, maintaining of the blood pressure is the most important thing which you have to do during the procedure. And high-risk patients should be identified and they assessed, and you should become alert to it. Thromboembolic prophylaxis is also important. So these are the very commonly peripheral nerve injuries that occur. Ulnar nerve 25%, brachial plexus 19%, spinal cord, lumbosacral nerve 15%, sciatic and peroneal 5%, median and radial nerve 3%. So this is extremely high. For me, even if it is 1% and it happens to your patient, it is too high. It's too high to accept, because you can be litigated for this because of your inattention to meticulous detail intraoperatively. Now, my colleague, Dr. Ketan Desai, is a world expert in peripheral nerve surgery. So we do a lot of these cases that are referred from outside. So the incidence of peripheral nerve injury is extremely high. So please be careful and be obsessive about your positioning. That's why I just put the slide up here. And this is one of his slides I've just borrowed, that position-related iatrogenic nerve injuries. These are not our patients. But so he has described 7 patients, brachial plexus nerve injury, 4 patients, 1 bilateral brachial plexus injury, peroneal nerve palsy, 3 patients. And you get other causes also of nerve injury, but this is related to the position. So there's an ASA advisory on the prevention of peripheral neuropathies. Pre-op assessment is important to assess the patients who are at risk. Upper extremity positioning, arm abduction should be limited to 90 degrees in the supine position. Lower extremity position, lithotomy position may stretch the sciatic nerve. Prolonged, this may happen in non-neuro surgeries also, like TURPs and gynec procedures. Prolonged pressure on the peroneal nerve at the fibular head must be avoided. Protective padding should be provided. Padding at the elbow and the fibular head may decrease the risk of neuropathies. And so properly functioning automated BP cuffs on the upper arm do not affect the risk of neuropathies. Shoulder braces in a steep head down position may increase the risk of brachial plexus neuropathies. And post-operatively, you must assess. And I will say not only assess, you also assess and document. It's very important that you document that it was uneventful. one of the most important things in positioning is effective communication. Communication among team members, your colleagues, your seniors, in choosing the position, in implementing the position, and in post-operatively. So normally I take the role of the team leader. Anybody can take the role of the team leader. And just like how we give the log role, it is done as a well orchestrated effect. One man, one person cannot do this. So you normally disconnect all your lines. If it is necessary, turn the patient on a count of three. When I count three, you could turn the patient around or give the final position. Then I told you once again, auscultating before and after is very important. And effective communication is one thing which is not taught in the syllabus, but now it is a very important soft skill to acquire as you go along. Another important thing I'll give out a message is call out for help. Or if you give a message, you must call that specific person. When 5-6 people are involved in this positioning, then you just say, okay, now somebody hold the head. You must mention that person's name. I call out that person. Suppose my attendant in the OT is Amit. Then I say, Amit, do this. Then he says, yes, sir, done. So you close the loop of communication rather than just firing out instructions in the air, which nobody may be listening to. My take-home message is positioning of patients under anesthesia care is a major responsibility requiring meticulous attention to detail, teamwork, and constant vigilance. Proper attention to the pathophysiological effects of positioning is important. Improper positioning can cause injuries, and most of them are preventable. Ideally, the final position should appear natural, a position that the patient would comfortably tolerate if awake and unsedated for the anticipated duration of the procedure. We are what we are, what we repeatedly do. Excellence, there is not an act, but a habit. So in this positioning, make sure you do these good deeds every day, repeatedly, so that it is not a one-off that you do when you are encountering a difficulty. Thank you.
Thank you, sir, for a wonderful presentation touching the basics. Divatia, sir.
Yes, thank you, Dr. Monteiro. So we'll have some time for a few quick questions and answers. So I think you very comprehensive coverage of the major positions that you use in neurosurgical patients, and lots of practical tips, very good pictures. And I think whoever watched this presentation will get a very good flavor of what to do, how to do, and maybe what even not to do. Okay, so the questions are, is a flexometallic tube required in the supine position or the standard tube okay? And in which positions will you actually want to insist on a flexometallic tube?
Okay. I will use a flexometallic tube in the supine, in the prone position and in the lateral position sometimes. Not necessarily in the supine position.
Sitting as well.
Yeah. Sitting, yes, yeah. And the other thing is also that in case there's an intraoral approach, which we very rarely do, then you may have to use a armored tube.
Oh, so related to tubes.
And cervical spine injury, cervical surgeries, I may use a armored tube in the supine position. Maybe that is the indication, common indication.
Spine surgery.
Just to add, sir, can I add?
Yes, Manisha.
Yeah, in supine position, if his neck is extremely flexed by the surgeon, then also flexometallic tube is recommended.
Yeah. So related to tubes, there was a question about what if the tube pops out in the prone position? And the other question I want to add on is, even if you have a tube-related problem in a patient who's got a tube, but with the Mayfield clamp and all those sort of things in, how do you handle the...
Okay, so now to the question of the tube popping out, like I think most things in life, prevention is better than cure. So these steps pre-operatively, if they are done, as I mentioned, fixing the tube, putting that gauze piece, it will ensure that it will not pop out. Anyway, if it does occur, then you can rescue the airway in an emergent situation using a supraglottic device. But rather than reaching that situation, I think it's best to prevent all these instances. Now, Dr. Divatia asked one question. Suppose the patient on the Mayfield clamp. So I'll tell you one interesting complication. We were doing a deep brain stimulation case, and intraoperatively, when they were put in the stereotactic electrode, there was bleeding along that site. So that patient developed some, he got a seizure, and due to the seizure, he clenched his jaw. Now this patient was doing an awake procedure, the deep brain stimulation case. So in that case, now it was a very tricky thing to do, loss of airway with the stereo, that frame on. But I had a quick chat with the surgeon. We gave away the priority. We removed the frame. I intubated the patient, and we rescheduled the case on another day. Now here you the dilemma, because that surgery was already going for 2-3 hours. So now whether to just carry on that way, but we thought it is best that we reschedule. We told the patient that such a thing has happened, and it's okay. So we will do it again the next day. So airway will always be the priority for me. Safety and airway.
So let's say the tube is displaced or have an airway tube-related problem with a patient, if not with a clamp on. Can you switch to a laryngeal mask or something in such a situation?
So now each one has got his own flavor, but then eye gel some people prefer. I will prefer a supraglottic device which I can inflate the cuff myself. Because what happens, the eye gel, it goes in, but it's the thermoplastic material, it will inflate in its own time. But I want some control. So even a ProSeal, if you don't have access to LMA Supreme, I put in a ProSeal LMA and secure the airway. Supraglottic device, second generation, with a cuff which I can inflate. That is my.
So that's easier to do with
easier.
Yeah. Okay. So some practical points about you mentioned that you always take your IV and this thing on the upper arm when your patient is lateral. What about NIBP, and can you take veins in the lower limbs? The IV in the lower limbs.
Okay, you can take veins in the lower limb. The NIBP cuff also somebody asked.
Yeah.
So if I've got my arterial line, that NIBP cuff is on a manual mode. So I shift that also to the upper limb. Anyway, I've got arterial line in. So that NIBP cuff, for practicality, I put it on the upper limb also. But it is on the manual mode. So if I require, very rarely I can check it. Now in the foot. Now some people, I always also identify a vein on the foot in case I have to give some fluid. But I prefer not to do it.
Okay.
Yeah, understood. In children, it's a good idea to take that vein because you can get good access. But in adults, I just identify the vein and keep it. In case I have to do it, I can put it. But preferably, I go for a good cubital vein and a peripheral vein, 16-18 gauge.
Okay.
Preferably, don't take it because we are talking about the thromboembolic phenomenon and all that. So if you can avoid it, best avoid it. If you have no other option. Now, these scenarios which are coming up are very rare. You know, try to. So, of course, I will say best avoid in the foot unless there's no other option.
Okay. Is a central line mandatory in someone for patient in the sitting position?
Yes.
It is mandatory.
Yeah. Okay. There's no compromise there, and sometimes because that's the only way you can aspirate the air well. In fact, they say it should be done with ECG guidance so that the tip of the central venous is exactly at the entry of the SVC into the RA. So you will know that. So do an ultrasound guided. The only thing of this neckline sometimes is in aneurysm surgery. Suppose you want neck access on that side. But even then, I put it on the opposite side. Or if the surgeon tells me that for some reason I want it and only the right side is accessible, then we make a little compromise there. We discuss among ourselves. If only he requires neck access on the right side, then I put it on the left. But I will prefer to put it on the right side because the right side is easy to access, easy to aspirate.
Okay. So you mentioned that, prevention is better than cure in fixing the tubes. So do you always put an oral airway in the prone position and fix the armored tube with the airway?
Now, good point. So now what will happen is, sometimes we are doing this intraoperative monitoring like MEP, SSCP. Suppose we use it. Now, what we have done is we have published one article in the airway journal. We have my colleague and me, we have experimented. We put a boxer's mouth guard. I've secured that boxer's mouth guard. So we put that on the upper teeth as well as the lower teeth. And I put in a large, well-folded gauze piece. When you put that gauze piece, it should be between the molars so that the patient doesn't clench the jaw. I prefer not to put the oral airway because sometimes it may cause more harm than good. It may cause some amount of damage. So I prefer not to use the oral airway. I put a boxer's mouth guard and I fold a gauze piece and I put in, and then make sure that the gauze piece is behind the molar so that it cannot clench the jaw. If you don't have a boxer's mouth guard, then you put the folded rolls between the molars.
Dr. Montero, what is the problem with the oralates when the stimulation is going on during nerve?
Yeah.
Okay.
And I put an armored tube also.
Yeah.
So I put an armored tube, so the chances of him clenching the jaw are less.
Okay. So I don't think there are too many other questions over here, except of course lots of compliments for an excellent presentation. I want to ask both you and Dr. Manisha, because there was a question on some medical legal things. So for Manisha, there was a question is that if a patient who with no risk factors has a stroke, or with risk factors has a stroke, are there any medical legal implications for us? And Dr. Montero, for you, have you experienced any medical legal issues out of those patients who had nerve injuries or complications because of because of positioning related problems?
Sir, regarding the medical legal issues in a patient who do not have risk factors for development of perioperative stroke. Sir, the medical legal issues can definitely arise, but then though they arise, we have to have if we document properly regarding the preoperative assessment, and if there is no risk factor, then I don't think there will be any problem for the anesthesiologist in delivering the anesthesia, and if the patient develops a perioperative stroke. Okay. So medical legal issue is the concern with the patient's relatives, as if the patient develops stroke perioperatively. But if there is no risk factor, and if there is a risk factor, and if it has been documented properly, a special informed consent has been taken, everything has been explained to the patient's relative as well as patient, and I don't think the claim will be for the medical legal issue will harass the anesthesiologist. So documentation is very important.
Yeah, so I think that's a good message, that document everything, do everything as well as possible. Patients are free to sue anyone whenever they feel like, but as long as we've done our job well and documented everything clearly, we should be okay. Yeah. So, Dr. Montero?
Yeah. So the question to me was whether I have had any medical legal no. Fortunately, no. So now I will just add to it. Fortunately, no. But I think proper technique, of course, and I also feel communication with the patient is very important. Very often, if the patient has an issue, it's better to call the relative down, communicate with the patient's relative, place everything on the proper, and a little honest discussion is very important. Very often, patients feel cheated because they have not been told. So, once again, communication, I think, with the patient and documentation, of course, very good what Dr. Manisha said. Communication with every stage during the event is very important. Call the patient down, update him, like how we do it in the ICU. Keep them in the loop, keep on briefing them what is happening. And most patients will be quite happy with that. At least you've been honest with them, you've communicated, kept them in the loop.
Sir, informed consent regarding the perioperative consent should be taken by the anesthesiologist, not by the surgeon or by the attending physician. It should be taken by anesthesiologist.
That's also a good point, that you should always make sure you've told them whatever is the problem, potential problems. Two quick questions, Dr. Montero, then I think we are running late. What vasopressor do you use if there is hypotension when you're giving sitting position or something like that? And the last one is, do you ever put a stitch to fix your endotracheal tube?
Okay, so now the vasopressor depends upon the patient. So if the patient has got a normal heart function, then I will use phenylephrine. I don't use boluses. I always prefer to use an infusion. I keep a background infusion of phenylephrine on. If the patient has got a little compromised cardiac function, then I prefer noradrenaline. And now the beauty of phenylephrine is it doesn't increase the heart rate. So I prefer phenylephrine. But in case suppose the patient has got a compromised heart function, then I use noradrenaline in a titrated dose, also as an infusion. And what the other question was?
How do you fix a tube? Have you ever taken
No, I just fix it with the normal the sticking plaster. I've never ever taken a stitch. Okay. I think the stitch comes in a head and neck surgery, sometimes in the tracheostomized patient or that, but we have never in neurosurgery.
Yeah. Have you ever had the armored tube kinking?
No.
Okay. Okay, so I think we've no more questions over here. So I want to thank Dr. Montero and Dr. Manisha for excellent presentations, very detailed coverage, very practical points that you've raised and handled all the questions beautifully. I hope the viewers, the listeners are satisfied with all the queries and for the wonderful presentations. Lots of compliments to both of you for your presentations. So thank you very much.
Thank
And
you.
I now hand over to Dr. Edward Johnson.
Thank you, sir. So today it is a great day for our online anesthesia. You two speakers and the moderator has made a great day. There are so many viewers, more than 600. It is equivalent to a state conference. So that case presented by Manisha Katikar, the topic was very rare topic, but she handled it very nicely, and he has given more points to the practical points to the practicing anesthesiology. Thank you, madam. And regarding the topic for Montero, sir, he has touched all the basics and given more points to the postgraduates and also the practicing anesthesiologists. Thank you very much, sir. Thank you, Divatia, sir. You have handled the discussion in a great manner. As a third topic here, consolidated the take-home messages also. That is very nice. Thank you, one and all. We will meet next week with an interesting topic. Meanwhile, I thank the sponsor Akurla and the host A1 Logics and all the media partner Anesthesia TV. Thank you, one and all. We will meet next month. Thank you, sir. Thank you, one and all.
Thank you.
Thank you so much.
Thank you.
Thank you all.